Welcome to the podcast, Not Your Doc Anymore, where we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of physicians who understand clinical practice and are actually counseling with patients on a regular basis and have had years of experience. Here to address the topic of breast cancer is an amazing general surgeon, Erika Lloyd. Thanks for coming.
Great. Thank you so much, Darren. I really appreciate it.
This is great. Dr. Lloyd is board certified as a general surgeon with special interest in the treatment of breast disease and breast cancer. She received her bachelor's degree from the University of Vermont. What was that degree in?
It was like a biochemistry degree. So
Oh,
I was
okay.
always a scientist, but not pre-med. That happened later.
Is that right? Did it?
Yes,
Oh, wow. How long after undergraduate did you decide to do that?
a year. I was
Okay.
actually had a job at a pharmaceutical company as an organic chemist, making,
Wow.
inventing antibiotics.
How
And
amazing.
then I really felt that I needed a more people intensive job and always had a passion for helping people. So it was a natural progression for me to go to med school.
How awesome. I didn't know that story.
Yes.
You then attended Tufts Medical School in Boston, Massachusetts. She had completed her surgical residency training at the University of Utah. I know that we crossed paths for a year or two, but I remember you maybe as a chief resident because I started in 1997. You completed your residency in
Yes.
1998, right?
But residency is a crazy time. We never remember anything from residency because all we do is work.
That is so true. I'm just going to say a few personal notes. Erika loves the outdoors, and it was difficult to get her on the show until we knew that skiing up in the mountains would be a little less favorable. But we're doing this early in the morning so you can get out on the ski slopes, correct?
It's
That's all right.
true. It's never too
Okay.
late to ski, even in July here.
I love it. I just have to say, Erika, I came to St. Mark's Hospital in 2005 at the times that you do remember things because you're not working
Yes.
as crazy. And you have been so amazing taking care of all the many patients that I had with breast lumps and provide just that calm, reassuring voice to be able to walk somebody through what I think is a really stressful time.
Yes, it was an easy progression to specialize in breast for me because of my passion for women's health. And I feel like it was back then, because now I'm old, an underserved community. And it was a really easy transition for me, which of course I still love today. These women are always amazing. And I feel there isn't as much as there should be out there to help educate women, and that was my passion project.
That's great. Well, let's just dive into it with that intro. Can you explain how someone can determine their personal risk of breast cancer and what steps can they take if they are at high risk?
Yes, there's a great tool that has become pretty much the standard of care, the Tyrer-Cuzick scale/score. And that is something that estimates your lifetime risk of breast cancer. The beauty of the internet, you can actually go on, put your own details in, and get a good estimate. Most of the radiology departments will do that for you when you go for mammograms in this day and age. And it puts in a lot of your personal and family history to decide what your lifetime risk is. Of course, it's age, height, weight, family history that will help us to decide. Women who have a higher than 20% lifetime risk, we now supplement their screening with breast MRIs, which is a big change in my lifetime.
Okay. So, are there any additional steps that somebody needs to take if they are at high risk of having breast cancer?
Well, of course, it's notifying your healthcare provider. Some healthcare providers aren't as up to date with the risk, so I always believe women should be their own advocates in their health. And so it is alerting your healthcare provider your risks and family history is of utmost importance. I feel it's a collaboration with you and your healthcare
That's
provider.
great. How can providers do more before they get to you?
Well, of course, it can be easy to find out the risk of patients by doing this simple scoring process. And most radiology departments do make that easier because if you are getting the mammogram report on a patient, a lot of times you can see this Tyrer-Cuzick score, which will help you decide if you should order a yearly breast MRI to supplement screening. And luckily, it has become more standard of care. So a lot of care providers are seeing this and ordering breast MRIs.
That's great.
The other great thing is genetic testing. With a strong
Great.
family history, even if you yourself don't have breast cancer, genetic testing is becoming more part of the process. If you have a family relative with ovarian cancer or multiple family members with breast cancer, other cancers are also included. Genetic testing can be covered by insurance. Even if it's not at this time in our lives, genetic testing has decreased significantly in cost. A lot of
Okay.
patients have a minimal out of pocket cost if their insurance won't cover it.
That's great. So, what is actually being tested in the genetic test? Sure that it's expanded, probably even in the 2 years that I haven't been practicing medicine.
Probably not in the last 2 years, but it has expanded. Back in the day, the BRCA genes were the first to be discovered, and those are the ones most people know about. But there's so many other genes that we test for now. A lot of these up-to-date genetic testing companies will check for CHEK2 and PALB2, then the list goes on, which is
Yeah.
nice too, because not all genetic mutations have an extremely high risk of breast cancer. So there is variability in that. So with the detailed individual information on genetic testing, it helps guide surveillance or discussion of other options like
Right.
prophylactic mastectomy.
Okay. We'll talk a little bit more about that as we go along. Will you review some of the cancer screening methods? And are there any advances in technology that influence accuracy and effectiveness of this screening?
Yes, so the newer thing, which actually is now standard of care, is the 3D mammogram, which does get a better view of the breast tissue because it's not just two films like the old fashioned when we grew up, Darren. And it can help,
Yeah.
especially in women with dense breast tissue. Of
Great.
course,
And
if
so that
you
has become more standard of care?
Yes, and I
Good.
recommend to all my patients find a facility that does 3D. In the rural communities, they may not have this. And of course, in those communities, we have to do the best we can. So I do recommend women in rural communities, if they can't find a facility that does 3D, please do the 2D because it is better than nothing. But
Gotcha.
in big cities, it's there's no other except
No other
3D.
way to go. Yeah. So talk to me a little bit about MRI and what are some of the advantages of using an MRI? What are some of the disadvantages of MRI?
Yes. So the advantage to an MRI is in women with dense breast tissue, breast cancers can be missed. And even without dense breast tissue, 15% of breast cancers don't show up on mammogram.
Wow.
MRI helps. MRI can see more. Now, of course, the downside to MRI, it sees more, and women
Yeah.
have a false positive rate. And by that, I mean 20% of women who will get an MRI, we see something that requires a further workup, ultrasound, biopsies, and it ends up being benign. That
Yeah.
is why we use MRI in high-risk women only and not as a screening tool in all
So if
women.
that's great. So if we have a false positive rate of 20%, what are the ones that we are not missing? Because that's what we really worry about in screening.
Yes,
What's
it's
the false
very
negative?
low, a few
Great.
percent.
Oh,
And
great.
of course, that varies on who's reading the MRI, but it is
Sure.
really low. Not zero, unfortunately, but as we know in
Okay.
life, nothing's zero.
Yeah, I know. So true. We're going to just shift gears just a little bit. Are there any lifestyle changes that listeners can do to help reduce their risk of breast cancer?
Yes, a lot has to go on healthy lifestyle, which is tough because I ask patients to do the hardest thing. Losing weight and exercise have been shown to significantly decrease a lifetime risk of breast cancer. Of course, that decreases risks of so many other cancers and other health problems, diabetes, hypertension, but it
Sure.
is tough. I'm asking
Yeah.
patients to do the hardest thing. So I usually counsel my patients be the healthiest you, because of course we still have to live.
Yeah. We have to live and ski.
Of course. Or whatever your passion is.
That's good. So is the reason for weight reduction, is that because of a decreased exposure of estrogen to the breast? Is that what happens?
Yes. Yes. And there probably is a factor of excess weight has a detrimental effect on our immune system as well.
Mm,
And our immune system helps us fight cancers. But it
yeah.
is interesting in the breast cancer world, we have done studies that show exercise decreases the rate of recurrence in breast cancer. Exercise alone.
That's great. Awesome. Are there any dietary recommendations that are out there to help us prevent breast cancer? Such a
Well, of
popular topic right now.
yes. And of course, that can turn into a deep rabbit hole. I really do try to keep it basic. Less processed food. Again, that can be challenging when you live in America. Less processed sugar, more fruits and vegetables, less red meat. But again, it is finding a balance that works for you. As I'm sure you have found in your practice, I hate the word diet. It doesn't work. It's a four-letter word and should be stricken from our vocabulary. So I do focus on lifestyle changes.
That's
I'll
great.
counsel patients, whatever you do to lose weight, you've got to be able to do when you're 80 as well.
Yeah. With your science background, and I mean, we're scientists, let's be honest, as physicians, we study all these things. You have to admit that there's got to be such a significant challenge to figure out what diet's impact is on something like breast cancer, right?
Yes. And that just goes by every person is an individual. And we've got to find what works for them. And that's the frustration I run into with a lot of patients. They've tried everything, it doesn't work for them. I do send some of my patients to dietitians for some counseling because it is such a big field.
Yeah, that's good. Well, we actually did have a dietitian on just that will come out this week, so we'll be excited to hear some good recommendations. I don't know if she used diet as a four-letter word, but I do love that. I'm going to take it on.
Yeah.
That's good. All right. What are some common misconceptions about breast cancer prevention? What does the evidence actually say? Is there anything that we have out there?
So the biggest one I hear is women will come in and say, I don't have a family history of breast cancer, so I thought I would never get it. And of course, the data says 1 in 8 women will get breast cancer. That is
Um,
so high when you think of all the women in your life. 1 in 8, very high. And a
yeah.
lot of those women have no family history of breast cancer.
Okay. Wow.
So that's
That's
why yearly mammograms are of utmost importance. The second misconception I hear is, as we know, there's so much in the news that isn't data driven. Some women will come in and say, I heard I wasn't supposed to get a mammogram till I was 50. I hear the other end of the spectrum as well. And healthy 80-year-olds will come in and say, I stopped doing mammograms because I thought I was too old to get breast cancer.
so how long should women continue on getting mammograms
That is
with
a
that?
tough. In women who are healthy and have family members who lived into their 90s, I feel they should be getting mammograms well into their 80s.
Okay.
And so I do like to individualize care. Of course,
Sure.
there are a lot of women who have underlying health issues or their mobility is so poor, it's hard for them to get a mammogram. Those factors can change the age. But as we know, women are living longer and longer.
Yeah.
And I have a lot of healthy 85-year-olds who statistically will live into their 90s
Yeah. That's great.
with quality of life.
What is our early age recommendation right now? Is it 40? I
So
remember that
it
we
is
lived during the
40.
the era of Michelle Obama, where I think they came out with recommendations and said 45, and I remember Michelle Obama says, "I'm starting my mammograms at 40." Do you remember that?
Well, I do. And I loved her for that
Yeah.
because as breast cancer surgeons, we all believe 40. It is challenging because a lot of women at 40 have dense tissue and it can be difficult to read mammograms, but there are things that show up in young women with dense breast tissue, like calcifications, which can be a sign of an early stage breast cancer.
Okay.
And we do know the earlier we catch breast cancers, the more successful we are with treating and survival rate.
Great.
Now, with high risk women, we will start earlier at 35. And in high risk women, we start MRIs sometimes as young as 25.
Wow.
And that's
Wow.
why I feel it's so important to know your risk, be your own advocate. Talk to your healthcare provider so that you can formulate a plan on how best to be followed.
It's great. We're going to walk down this road because this is where you've been so amazing. I know you've given me your personal cell phone number, not that it's you give that to everybody, but to be able to reach out to you at a time when somebody has a breast lump. So my question is, what should a listener do if they feel a breast lump, and when should it be evaluated?
I feel that does depend on the patient and their history.
Hmm.
Sometimes in women with a really dense breast tissue, if it seems like a fibrocystic mass on exam to a provider, you can wait a month or two to see if it changes with that patient's cycle. But mostly, we immediately get a diagnostic mammogram with a possible ultrasound.
That's
It's an
great.
easy, cheap test. And of course, it's not 100%. So, for providers, if you get a mammogram and ultrasound and it's negative, the patient still needs to be followed either by a referral to a breast surgeon, or a follow-up in the office 3 months later. That is something else I have seen. Women are told this lump was benign. Mammogram and ultrasound didn't show anything, and it changed, but they still thought it was benign. So
Yeah.
changing lumps need to be evaluated further, even with negative testing.
Yeah. Especially with lumps that persist or grow in size over
Yes.
time. Yeah, that's always the thing that I had a challenge with is, okay, we've got the negative test now, but if this persists or you're having continual problems, we need to see you back.
You are exactly right. And that's what I feel we should all be counseling patients. Because if you're the perfect doctor and the patient is perfect and gets all of her testing, we still missed breast cancers. It happens. So I agree with you, Darren. Anything that changes needs to be evaluated again.
Okay, let's say they have a persistent breast lump and there's a need for biopsy. Where are those taking place for most patients?
Most patients are getting them in the radiology department.
Okay.
Some some physicians have an ultrasound machine in their office and will do biopsies in their office, but it's nice to have a radiologist do it with mammogram and ultrasound and then deciding which modality would give a more accurate biopsy. Back in the day when we started, Darren, there was these FNAs, which are very small needle biopsies, and they aren't as
Hmm.
accurate. In the radiology department, there's a larger area biopsy, which gives us more accurate results. They
Gotcha.
also place clips at the time of biopsy. So, either way, what if it comes back benign? You can always see that clip on future mammograms, and we know that clip is marking a benign mass and can't be confused with a new lump.
Gotcha.
Again, if it's cancer, we can find it at a later date to be removed.
Gotcha. Okay, what are some of the common treatment options for breast cancer, and how do they vary by stage and type? And feel free to just speak freely on this. And I know this is kind of your passion and where you really
Yes,
excel.
it is. And luckily for women, breast cancer treatment has changed. And that is why we call it practicing medicine. We do things differently now than I did 10 years ago, 20 years ago in practice. And of course, that benefits women. Staging is important. There's stage 0 to stage 4, but more important are the receptors on the cancer cells to help guide us in treatment. It can be anything to surgery alone for treatment and cure to,
When you say surgery alone, just a biopsy? I mean, just
well,
a lumpectomy?
yes. So there's a stage 0 breast cancer called DCIS, ductal carcinoma in situ.
Mm-hmm.
And in older women, if we just remove that, they don't need other treatment like hormonal therapy or radiation. In younger women, we do treat this DCIS stage 0 breast cancer differently because, of course, they have a longer lifespan and we're looking for decreasing recurrence rates. So,
Okay.
a lot of treatment has to do with age, stage, receptors on those cancer cells. And by receptors, what we're talking about is what causes that cancer cell to grow. Most women in their cancers have estrogen positive breast cancers,
Okay.
and they can be treated. We call it hormonal therapy, but it's actually an estrogen blocker. And that works extremely successful in decreasing recurrence rate.
That's tamoxifen.
It's tamoxifen in premenopausal women, and now we have anastrozole in postmenopausal women if it's invasive. So we have different hormonal treatments.
So for DCIS, if somebody has that, that means in situ means it hasn't crossed through the plane of the cells.
Yes. Because, of course, the risk of breast cancer is it spreads outside of the breast. Bone, lung, or liver are the most common. And with DCIS, we say biologically, it doesn't have the ability to spread outside of the breast. And that's where local treatments come into play.
Gotcha. How about a stage one? What are typical things that you have to do for a stage one? And when do you start extending into node biopsies and maybe
Yes.
additional follow-up testing? Or, I mean, does PET scanning in breast cancer treatment, is that something you do or other
Yes.
things?
There are cancers where we pretty much immediately get a PET scan or other scans, CAT scans of the lung, abdomen, and a bone scan. Unfortunately, we live in an age where insurance companies tell us what
Mm,
tests we can order, and we have found workarounds that are safe for patients. So, PET scans happen when we're worried it's already a stage 4 breast cancer. And by stage 4, I mean it's spread not just to the lymph nodes, but to a bone, lung, or liver.
hmm.
Because we do have different treatments. There are hormonal treatments for patients like that are very successful. And we have immunotherapies. And this is all on an individual basis. That's been a nice change in the breast cancer world. Of course, we have all this science and all these studies because breast cancer is so common. Now we have to extrapolate that data to an individual, and that's getting easier and easier to do. So it used to be stage 1 breast cancers didn't need chemotherapy, but that's changed with triple negatives. There's also this HER2 positive cancer. And the HER2 new is a protein on the cell that we've discovered years ago, where we know that cancer is more aggressive than the typical breast cancer. So it's a complicated topic. Patients
Sure.
will always say, what treatment am I going to have if I do get breast cancer? And I have to say to them, we've got to wait and see what type you have and get the extra data. And that guides because there's such a large spectrum of breast cancers, and every breast cancer isn't the same, even if it's in the same stage or it seems to be in the same group.
When do you typically introduce like radiation therapy and chemotherapy? Is chemotherapy now more immunotherapy?
A lot of times, chemotherapy and immunotherapy are combined in women with breast cancer. But again, that's a huge spectrum. So there's a lot of variabilities. The biggest one for chemotherapy are the receptors on the cancer cell. There are triple negative breast cancers and the HER2 new positive breast cancers that a lot of them do require chemotherapy. We also have switched, now that we have more knowledge and data, to neoadjuvant chemotherapy in a lot of women with those types of breast cancer. But the typical breast cancer, chemotherapy is decided after surgery. So most of the time, the first doctor that a woman diagnosed with breast cancer sees is a breast surgeon. And I'll be the first one they see, and I'll decide, do I feel they're a candidate for neoadjuvant chemotherapy, depending on all these factors. But a lot of patients will come to my office and say, when do I see the radiation oncologist? When do I see the medical oncologist? And for the typical breast cancer, that's after the surgery results are back because that helps guide us on the further treatment.
Are there times where you do an initial lumpectomy and then have to go back and do additional surgery?
Yes, Cancers, as we've already been discussing in this podcast, can do whatever they want, even though the imaging says the cancer is small. Some cancers can be larger than mammogram, ultrasound, even breast MRI feel. Even intraoperatively, I can't feel the extent of the cancer. So we go in and do a lumpectomy, and a few days later, the pathologist calls back with the information that there's a positive margin. And what that means is the cancer is touching the edge of the specimen. And as you can imagine, at that point, we worry there's cancer left behind. About
Gotcha.
10 to 20% of lumpectomies require a re-excision. And again, that varies for a lot of different reasons, including the type of cancer.
We're going to enter my field for just a little bit, but they say that one of the strongest predictors of emotional well-being in cancer survivors, besides sexual function, appearance, and employability, is feeling healthy enough to be a parent. And parenthood can, they say, represent normalcy, happiness, life fulfillment. And cancer survivors are often concerned about the risk of cancer recurrence, infertility, miscarriage, achieving a successful pregnancy outcome. They're also fearful that their history of cancer and its treatment will have an adverse effect on offspring conceived after their cancer treatment, such as placing them at risk for malignancy and congenital anomalies and impaired growth and development. So my question is, how do you approach the complex topic of fertility after breast cancer? Because I know you're seeing younger patients now.
Yes. Yes, they are younger and younger. And that is one of the things we talk about is their family planning. There are some women who, as you've mentioned, still are in their years of forming a family, growing a family. Chemotherapy can change that. If young women are about to get chemotherapy for breast cancer, we do get them to a fertility specialist to talk about options of egg retrieval for later fertility issues. And of course, living in Salt Lake, we have specialty doctors that deal with that issue up front. These hormonal therapies also interfere with pregnancy. The one we use for young women, tamoxifen, as you previously mentioned, you can't be on there when you're getting pregnant. And that's always a complicated and individual risk assessment. What is the risk of that particular patient going off tamoxifen, having another child? That's all factored into the decision. And our goal as physicians is to give them as much data as we can, knowing it's impossible to extrapolate all the data to an individual,
Sure.
but the statistics that help them make the best decision for themselves.
I'm sure patients appreciate that. So for people who are at high risk because of genetic testing, I know this is very individualized. Again, I saw a lot of these patients who knew they had the BRCA gene and knew they were at high risk. What are some of the potential treatment options that a patient could expect if they had something like this? And I know there's great counseling available for these patients. So any thoughts?
Yes. Anyone who tests positive for a gene really should see a genetic counselor to really get all the data. Because one, each gene does carry a different risk of other cancers as well. Ovarian cancer, colon cancer, stomach cancer, pancreatic cancer. So it's nice to get that individualized counseling from someone who's been trained because every gene's different. That could be one of the misconceptions too. Anyone who has a BRCA gene needs a double mastectomy. And of course, there's all guidelines for that. But for the most part, Women, even with the gene, if they're followed closely and get mammogram alternating with breast MRI, it can be safe to continue surveillance. The other option, which a lot of young women choose, is a double mastectomy for prophylactics, meaning how do we decrease their risk? Again, we have to counsel those women, even after mastectomy, you can get breast cancer.
Hmm.
It just
How is that
decreases your
followed?
risk. We don't do mammograms. So I
Yeah.
always, when my patients, I follow them for at least 10 years, sometimes longer. And when they're done with their reconstruction, or some women don't pick reconstruction, but they've healed from their surgery, I counsel them, this is your new normal. Here's what you look for in between my visit as a risk of breast cancer, even after mastectomies.
Mhm.
We
Good.
do nipple sparing mastectomies these days, which is a good advantage for young women because they feel more like themselves to have all the skin and nipple and just have an implant or autologous flaps put in to reconstruct breasts. And some of those, we actually do a mammogram yearly. If we
Wow.
feel there's enough breast tissue behind the nipple, I'll have women still do a yearly mammogram.
Many times at the time of the double mastectomy for prophylaxis, meaning that, and just for listeners, that means that there's no cancer diagnosed. How many times do we actually find cancers in that breast tissue? Do we ever,
It's pretty rare,
is it?
maybe 1, 2%, but a lot is because these are done for high risk women. They've already had their mammogram and breast MRI. So MRI can pick up early cancers so that we have that data before we do the mastectomies.
It's great. And then this question we've kind of answered, but we're just going to touch on it again. And I want to just ask, how can patients make the most informed decisions about their treatment plans? And I'm just going to say a few things. It sounds like we've got involvement with radiologists, we have involvement with genetic counselors, we have involvement with a breast cancer surgeon like yourself. Are there any other things that are out there that help patients make the most informed decisions about their care?
Oh, that is pretty impossible to address, again, because it's so individualized. And I love this about the change in medicine. As you know, when we started back in the day, a lot of patients just said, okay, this is what I've been told. I'm going to do that. Breast cancer
Uh,
treatment's so complicated because we are asking women to take these hormonal therapies that can push them into menopause. And as you know, in your practice, hot flashes, vaginal dryness, libido, it is complicated. A lot of women cannot tolerate these medications. So,
mhm.
in a way, it's a work in progress. But a lot of women are getting the data and making the best choice for themselves. And I really counsel my patients, go get the information, even if you feel like you don't want to take these pills, if you don't want radiation, because information's power.
Yeah.
And I do follow them all the time. It's a tough time in our history because of the internet. And I do weekly get that from my patients. Well, they say, and not going to a reputable site. Because, of course, there's a
Yeah.
lot out there that isn't science based. There are reputable sites like Mayo Clinic has a wonderful site. So I do counsel my patients, if you're going on the internet, go to a reputable site, get the
Okay.
information from there to help
And
guide you.
that's great. And, and I just have to make a plug for doctors like yourself. I mean, there is nothing but good intent to be able to guide a patient and to provide the best quality care. And there's nothing nefarious about what is going on with this interaction with doctors like Dr. Lloyd,
Right. Yeah, it
you
is a
know?
challenging time. And of course, I always counsel patients, they're part of the team. It's very important. I feel my job as the first person to see patients diagnosed is to give them a crash course in medicine, which is complicated because it's a foreign language, mainly Latin.
Yeah. Yeah.
So I feel that that's important, that they do need to educate themselves. And that's the upside to the internet. I feel that has changed in my career where women are educating themselves. And I feel that's important. Also, the follow up. Breast cancer is one of those where the surgeon and the medical oncologist usually follow patients for a decade because things change. Genetic testing is going to change and we can retest patients. Things can come down the pike that might be useful to patients or their families. You briefly discussed that. What's the risk of their children? And of course, that's where genetic testing comes in. But we know some families test negative, but their family history is so strong, their children still are at risk. And down the road, 5, 10 years, we might have a better handle on how to treat their children. So I feel follow up and education and advocacy is so important for these women. So I love when they want to get educated. That I believe helps their survival rate.
That's great. How can friends and family best support someone going through breast cancer treatment?
I always feel quiet support is the best. Breast cancer diagnosis is tough. It can be isolating to these women. And so many friends and family want to be helpful, but they'll say to patients, you have to have a double mastectomy, or you can't have a double mastectomy, or you'd be crazy not to do this. I had a friend or family member who did this, and this is what you should do. We
Mhm.
all mean well, but it can be very stressful for patients to have almost the pressure of that. And I'm sure you saw that in your practice as well. So I feel the best thing family members and friends can do is support and listen. And there is an advocacy in there. A lot of patients who are going through chemo or even surgery recovery might have a problem and not want to contact the healthcare provider.
Yeah.
And sometimes it's nice for family to step in and say, you should call the doctor.
Yeah, sure. I love that. Quiet support. That is such a powerful statement. Love it. All right. Well, we're going to just summarize what are the 5 things that you would like listeners to know to help them better understand breast cancer. And this may be a little bit of a summary.
Yes. And I'm pushing more for how do you advocate for yourself to, of course, prevent breast cancer, which is complicated, but the main goal is early detection. And that is 1, mammogram, 2, self exam and doctor exam. Get your doctor involved. 3, know your risk. And that's something that can be easily calculated on your own in the internet
Yeah.
or at the radiology department. Of course, be the healthiest you. So important. And it's the hardest thing to do, knowing we've got to live. And I always feel that's a big part of it. You've got to be the healthiest you, but we've got to have joy, happiness, living. Unfortunately, food tastes really good. And
Amen.
some days it's nice to be lazy and sit on the couch, but exercise in a healthy way are of utmost importance. The last and most important, we should be talking about breast cancer risk. Talk to your friends, get your relatives to get mammograms. and see their healthcare providers.
That's great. Wow. Erika, this has been priceless. Thank you so much.
You are so kind. And thank you for getting this information out, because I feel these are the perfect venues for women to hear things and act. Get your mammograms.
That's great. I can't tell you how many times we've had these discussions in the doctor's lounge about topics that I think are so relevant. And I also think that it's one of the reasons I wanted to do this, because I want people to know how important these conversations are, that doctors actually do care and want the best for their patients. I think it's such an essential message for people to know.
Yes, I agree. And thank you for bringing this to light, because obviously I feel women's health might be underserved, and I can't tell you how much I appreciate a venue of getting women information. You're amazing
Really,
for that.
yes. You're sweet. Thank you so much. Well, we just need to clarify that the medical advice for procedures do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that was provided generally. You can find this on Apple Podcasts, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok at Not Your Doc Pod or at DocWatts_. And we just want to thank all those who made this possible. Natalie Watts, our president and CEO of Not Your Doc Anymore, LLC. Our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and the production manager, Joshua Watts.